see webinar series, and this is going to be a 45-minute talk followed by 15-minute Q&A sessions. And you can put your questions in the chat box and we'll address the questions in the order that they are received. For your housekeeping, that please keep your phones or tablets muted during the talk. Now it's my absolute pleasure and honor to introduce Dr. Srinivas Chakravarthy, who is the American-born internal medicine certified in oncology and hematology. He's a senior consultant at Apollo Hospitals. He is the chairman of Subha Comprehensive Cancer Care Private Limited in Hyderabad, India. Dr. Chakravarthy served as a director of hematology and bone marrow transplant and Medical Oncology Cancer Institute in Hyderabad from 2020 to 2022. He has several publications in international and won several academic awards and has been invited to a faculty of numerous professional meetings and conferences. And so without further ado, I introduce Dr. Chakravarthy.
Thank you very much, Ruchi, and Dr. Saima, Dr. Jyotsna for having me here. So I see you have my slides. You're going to move the slides, I presume?
Yes, Ruchi is doing that.
1 second. So, well, good morning to all of you, I guess, although I'm in the evening time here. And thank you very much for the introduction. And I am now in the Apollo hospitals in Hyderabad, but I spent much of my Calo youth in the University of California, Davis, training and working as faculty there. So today I am here to talk about immunotherapy basically, and what the clinician would want to know from the radiologist. And we'll touch upon the basics of immunotherapy and cancer. And these are the contents of what I'm going to talk about: the role of the immune system, the kinds of immunotherapy, the outcomes, how do you measure response, who responds, biomarkers, any role for immunopet scans, and so forth. So can we move to the next slide, please? Thank you, Richie. So I'm sure you're all radiologists, but I'm sure you have some distant memories from medical school about the immune system. You know that the immune system is quite complicated, and it's a complex interplay between the B cells and the T cells and a variety of cytokines and the what are called the antigen presenter cells. But for the purpose of our presentation today and for its role in the immune system, the predominant cell that we want to talk about is a cytotoxic T cell, otherwise known as a CD8 positive cell. So this is the key cell that protects us from cancer. As you can see on the screen, the T cell is in the middle, and it has a variety of receptors. Now, when a cancer forms in the body, it sheds its antigens. Any foreign cell in the body sheds its antigens, and these antigens are recognized by what are called the antigen presenting cells, which then present it to the T cell, and the T cell recognizes it and causes and recruits the immune system. It releases a variety of cytokines to recruit the rest of the immune system and kind of launch a seek and destroy campaign against the said foreign cells. In addition, the CD8 cytotoxic T cell can also directly recognize a foreign cell, for example, a tumor cell, by means of certain receptors called the T cell receptors and the CD8. And it's activated, again, releases cytokines and can kill this foreign cell by cell-mediated toxicity. Now, these are like warriors in the body, and obviously nobody wants our warriors to run amok. We are seeing in Africa what happens now when warlords and generals run amok. So the warriors in our body, the T cells, also have brakes which inhibit its function, so that it does not get over revved up. And the most important, can we have the next thing, please? Thank you. So this entire system of the T cell and its receptors and the cytokines that it releases and its interaction with the antigen presenting cell is termed the immune synapse. So the immune synapse concept is very important for understanding of how the immune system functions in fighting cancers. So, and the next, please. So there are a variety of stimulatory receptors on the T cells, CD28 and the T cell receptor, which you can see on the screen as TCR and CD28, are the most important. There are also a variety of brakes on the T cell, very importantly, the PD1, CTLA4, and a variety of other inhibitor receptors, which prevent the T cell from being over revved up. And these are called the immune checkpoint inhibitors. These receptors, PD1, CTLA4, TIM3, LAG3, are collectively called the immune checkpoint inhibitors. Next slide, please. So, contrary to what a lot of people think, the human body is not an innocent bystander where cancer happens. All of you know that cancers do not happen in one day, and cancers happen as a result of a multi-step process. So you have a normal cell in the body which is mutating, and it acquires certain crucial mutations in a certain part of its genome. That particular cell accelerates, and first it becomes hyperplastic. Then it has to acquire several more crucial mutations before it becomes dysplastic, and then acquire even further mutations to become an outright cancer cell, and eventually, of course, evolve into to having metastatic potential and so forth. So when the cell becomes a cancer cell, it is now an abnormal cell that is no longer considered part of the human body, and it is a cell that has lost its ability for programmed cell death and is continually accelerating, dividing and subdividing. And it forms a lot of abnormal chemicals and abnormal receptors. It expresses a lot of abnormal proteins on its cell surface, which the body recognizes as foreign receptors or foreign antigens. So our immune system, as you can see on the left side, is quite active in recognizing these cells as foreign and trying to destroy them. So if you find this slide a little busy, I would suggest you focus on the middle three slides, the elimination, equilibrium, and the escape. So what happens is the immune system, especially the cytotoxic T cells, are able to overwhelm these foreign tumor cells and eliminate them from the human body, which is one of the reasons why most of us don't end up with cancer. Cancer is still relatively a rarer disease than heart attacks and so on and so forth. But cancer cells are continuously evolving and they're acquiring new mutations. So they can acquire mutations that confer on it the ability to withstand the cytotoxic T cell. And there is a state where there is a kind of dynamic equilibrium between the clearance by T cells and by tumor editing and the ability of the cancer cells to withstand. And this is a phase of equilibrium, which we see clinically as a phase of tumor dormancy. So for a detectable cancer to arise, it doesn't happen in a short while, it doesn't happen also in a couple of years. Most solid cancers happen over time, typically 5, 7, 10 years. And one of the reasons for this is this continued equilibrium or the tumor dormancy between the immune system and the cancer cell. Finally, it can happen that the cancer cell acquires further mutations, which allows it to overcome the immune system. It escapes immune surveillance and then allows itself to proliferate and invade the rest of the body. And that's the actual escape of the cancer cell from the immune surveillance. Can I have the next point, please? So this concept is called cancer immunoediting. The concept of how the cancer cells undergo elimination initially, can overcome that and get it in kind of dynamic equilibrium with T cell system, how it can eventually escape, is called cancer immunoediting. And the understanding of this concept is very important in our development of immunotherapy medications. So how do the tumor cells escape? They can do it by a variety of mechanisms. The most common mechanism that the tumor cell uses to escape T cell immunosurveillance is to lose recognized antigens. So whatever antigens the T cells recognize as foreign, the cancer cell merely sheds them and loses them. So it kind of flies under the radar. It becomes a stealth cell, so to speak. It can manipulate cytokines so that it secretes more inhibitory cytokines that can cause exhaustion of the T cell system. It can also upregulate certain molecules on its cell surface called the immune checkpoint inhibitor molecules, otherwise known as such as the PDL1, the programmed death ligand 1 molecules. So these molecules can press the brakes, the inhibitory receptors on the T cells, and cause inhibition of the T cells. This is one of the key things that has been studied and has led to the development of vast array of immune checkpoint inhibitors, as we will see briefly later. Next slide, please. So what is immunotherapy? Immunotherapy is not one kind of medicine. It's a whole class of medicines. In fact, several classes of medicines, all of which have one thing in common. They do not directly kill cancer cells. They unleash the patient's own immune system to achieve cancer kill. The next slide, please. So immunotherapy as such is not anything new. All of you know about cytokines, which we studied even in our medical school days. For long years, alpha interferon has been used in melanoma, interleukin-2 has been used in kidney cancer, and so on and so forth, which indirectly stimulate natural killer cells and other kinds of WBC in tackling cancer. I'm sure all of you have heard that BCG, the Bacille-Calmette-Guerin, it's a TB vaccination that is ubiquitous in the third world. All of us in the third world get TB vaccination with BCG, but it's a very good tool against localized bladder cancer, which is limited to the bladder surface, internal surface. You can do a resection, then instill the BCG, which will then recruit the local WBCs and stimulate local immunity against any residual bladder cancer cells, and is shown to be very safe, very effective in preventing the recurrence of bladder cancer and localized disease. There are a variety of immunomodulator molecules that we use in clinical practice. The most famous is thalidomide, lenangiamide, pomalidomide, which we use in multiple myeloma, melanoma, and all, which manipulate the cytokine release from the immune system, and therefore stimulate T cells and also inhibit neovascularization. Next slide, please. Monoclonal antibodies, most of you are familiar with that. Essentially, monoclonal antibodies are produced by the B cells within the human body against foreign antigens. That's called the B cell dependent cell kill. And we can artificially make monoclonal antibodies, obviously, in the laboratory, which are specific to certain kinds of antigens of interest in cancer care. So typically, these are derived from the B lymphocytes in mouse spleen. So this is a story of mice and men. And the nomenclature goes by how much mouse and how much man. So as you can see on the screen, the rituximab is very, very commonly used. Again, it's an anti-CD20 antibody, which is very commonly used in non-Hodgkin lymphoma, has increased the cure rates dramatically in a variety of B-cell leukemias and lymphomas. And trastuzumab is very commonly used against the HER2 antigen in breast cancer. Blinatumab now is a new drug that we use commonly in lymphomas. All of them have excellent results and have become part of the daily practice in oncology. Next slide, please. Next slide, please. We use vaccines. Of course, vaccines against, we know that many viruses cause malignancies, and vaccines against the causative viruses, such as the human polyoma virus, causing genital warts, which can lead to cervical cancer or penile cancer, HBV, HCV, which can cause liver cancer. There are vaccinations to prevent the viral infections and therefore cancers eventually. We can also make vaccines against specific tumor antigens. The most common one we use in clinical practice now is Sipuleucel, which is a specific vaccination made against prostate cancer antigens, and has been shown to be quite effective in prostate cancer that has advanced and has already undergone several lines of treatment. We also have a kind of vaccine, kind of oncolytic viruses are becoming the thing now. So One of the FDA-approved oncolytic virus is derived from HSV, the human simplex, herpes simplex virus type 1, which we can engineer to specifically infect malignant melanoma cells and cause cell kill of the melanoma cells rather than the human body cells. Next slide, please. CAR T-cell therapy has caught the attention of the world, of the oncology world, in the last 5 or 6 years, and its applications are rapidly proliferating. CAR, C-A-R, is short for chimeric antigen receptor T-cell therapy. What basically you do is that you take cytotoxic T cells from the patient's own body. You collect them by apheresis from the blood. Then you can actually insert an edited gene into this T cell, and you can teach this T cell to express receptors that specifically recognize the antigen of interest. And you multiply them multifold to get an appropriate dose per kilogram body weight of the patient. And then you infuse them back into the patient, just like a blood transfusion. And these CAR T cells, which have now been engineered to specifically recognize the cancer antigen of interest, can go and kill the cancer wherever it is in the body. And in some cases, it's showing fairly dramatic results in terms of response rate. The response rates are amazing, especially in people who have been heavily pretreated before and were thought effectively, are effectively left with no options. CAR T cells can give them a great option. There are about 6 CAR T cell therapies approved so far. The most common one that we use is the anti-CD19 CAR T cell therapy in a variety of B cell neoplasms, which are typically recurrent and have undergone at least 2 or 3 kinds of treatment already. The other one that's commonly being used now is anti-CD38 CAR T cell therapy in heavily treated multiple myeloma. We are seeing performance progression-free survivals in excess of 40%, 50%, which is hitherto unheard of in this particular class of patients. So dramatic results, at least in the short term. Long-term results, we still need to wait for mature data in terms of overall survivals over the long term. These therapies do not come without a price to pay. First of all, they're not commonly available. As you can imagine, if you require a laboratory which can engineer the genes, edit them, and then insert them into the patient's T cell, that's not commonly available. It's available only in select institutions in select countries. India, as of today, has none. So the closest to us is Israel and Singapore, where we send our patients if required. And it's quite expensive. It costs something like $150,000 to $200,000 in the US. And it comes with a fair amount of toxicity because these are hypercharged T cells, which are engineered and activated. They can cause a severe systemic inflammatory response syndrome. So cytokine storms and serious side effects can happen in the immediate near future. So this is something that we do in the ICU setting with very, very close monitoring. Next slide, please. So probably the most common immunotherapy that's in use as of today are the class called immune checkpoint inhibitors. So as we discussed, you have the T cell, the cytotoxic CD8 positive T cell, which has its activating receptor, the T cell receptor, which, can you press the next, please? And the next. So when you have a tumor cell in the body, its antigen is recognized and as the major histocompatibility complex, and the T cell receptor recognizes this and the T cell gets activated and it can cause tumor kill. One of the ways, as we discussed in a previous slide, that the tumor cell escapes this is by expressing a special kind of protein called PDL1, the program death ligand. Can you press the next, please? Which blockades the PD1 receptor, which activates the PD1 receptor on the T cell. Remember, the PD1 is the brake, it's the immune checkpoint inhibitor brake on the T cell. CTLA4 is another brake on the T cell. These are the inhibitory receptors on the T cell. So the tumor cell learns to secrete a PD-L1, a ligand that can actually activate the PD-L1 and put the brake on the T cell. So it effectively can cause radar jamming of the T cell. So what we can do is we can create a monoclonal antibody that competitively inhibits the PD-L1 protein on the tumor cell. Can you press next, please? And these are the drugs that are called checkpoint inhibitors. Next, please. So these are fully humanized, typically, these are fully humanized monoclonal antibodies, which are designed to either block the PD-L1, the ligand that's expressed on the tumor cell, or the PD-1 receptor itself on the T cell, so the PD-L1 can't stimulate it anymore, or against the CTLA4. So these are the three classes that are most commonly available now, the PD-L1 inhibitors, and I'm sure you keep hearing these names nowadays: atezolizumab, avelumab, durvalumab, PD-1 inhibitors, the pembrolizumab, nivolumab, and the CTLA4 inhibitors, ipilimumab, and the tremelimumab. So all three blockade agents are available now and have become quite ubiquitous in cancers. And the indication for their usage is expanding by the day. Approximately 10 years ago, they were mostly used in advanced cancers, but now they are moving into more and more cancer types and into the earlier settings. We're using them now in the adjuvant setting in some cases, that means after surgery. For example, triple negative breast cancer, where we use immune checkpoint inhibitors along with chemotherapy. And they are showing fairly decent results with a limited amount of toxicity. And we're going to see more classes as times go on, as the times go by. Next slide, please. So in this era of immunotherapies, rapidly proliferating immunotherapies, we face certain unique challenges which we did not typically see in the days when we used just chemotherapy. So chemotherapy is a non-discriminatory kill. It either kills the cells or it doesn't, and some cells escape, some cells don't. And where they escape, you see that as progression. In immunotherapy, because of the unique modes of action of immunotherapy, we see phenomena such as pseudo-progression or hyper-progression, true disease progression, or a differential response. So as you can imagine, not all cancer cells express the same amounts of the PD-L1 ligand. There's a tremendous degree of heterogeneity because these are rapidly dividing, evolving cells. There's a tremendous degree of heterogeneity on the amount of PD-L1 ligand that cancer cells express both within the tumor mass as well as in different tumor masses in the body. And it's a rapidly evolving scene, which means that quite often we see that there is a very good response in certain parts of the body, but there is not quite a good response or true progression in other parts of the body. So, for example, you have a malignant melanoma that has spread to the lungs and to the liver and to the bones. We sometimes see very good response. The liver lesions have been controlled very well. The bone lesions have disappeared completely, but the lung lesions progress. So differential response we see fairly commonly in this situation, and that leaves the clinician in a bit of a quandary of what to do after this. And there are certain established clinical protocols that we try and follow in dealing with the differential response. But what is most worrisome is the differentiation between pseudo-progression and the hyper-progression. Next slide, please. Can I have the next slide? So pseudo-progression is a well-defined thing that happens with immunotherapies. You do a scan, there's an apparent increase in the size and the number, and we are left trying to figure out whether this is a real progression or a hyperprogression or a pseudo-progression. The only way to really tell, each institution has its own protocol, and our own institution, our nuclear medicine team, has been very, very helpful in trying to figure out with in the scans what actually is pseudo-progression or hyperprogression or true progression. But the only real way of making it out is either by biopsying the tissue or by following with serial imaging at a minimum of 4 weeks apart. And with time, if the tumor decreases in size, then that's pseudo-progression. So the only defining thing at this point in time is either biopsy or serial imaging. Now, why does pseudo-progression happen? As we have just discussed, you have an exuberant immune response against the tumor cells, which is basically what you want when you use the checkpoint inhibitors or the other immunotherapies. Now, what that causes is this rapid influx of many immune-related and inflammatory cells around the tumor mass. Now, these inflammatory cells are picked up in the scans and can look like tumor quite frequently. They are not tumor cell proliferation, but the immune cell proliferations. Typically, in pseudoprogression, clinically speaking, the patient doesn't have any significant symptoms. And typically, we do not repeat a follow-up scan within 4 cycles of treatment of immunotherapy. I'm sure all of you know that when we give chemotherapy, typically scans are repeated after 2 cycles to see if there is progression or stable disease or regression. But in immunotherapy, typically we do the scan unless there is a clinical need. We do not repeat a scan for about 4 cycles because immunotherapies tend to work a little bit more slowly, and we avoid detecting problems such as pseudo progression. But sometimes when you do scans, even after 4 cycles or you do them earlier, we do see progression. If it is pseudo progression in the clinical setting, the patient is usually not very symptomatic or very minimally symptomatic. Pseudo progression has been described in something like 4 to 15% cases of immune checkpoint inhibitors. And the interesting thing is those patients who do have pseudo progression actually have better outcomes. And there's a lot of protocols being looked into now to try and detect whether we can pick up pseudo progression by imaging. So advanced imaging techniques such as PET scan, obviously very ubiquitous. We use that quite frequently. In the setting of brain tumors, we use the MR spectroscopy. That's very handy. Then diffusion weighted images, and so on and so forth. This recent evidence that large-scale data, analyzing big data, we live now in the era of big data, so analyzing big data and using radiomics and recruiting artificial intelligence programs can actually improve the detection rates of pseudo-progression versus true progression. Can I have the next slide, please? Hyperprogressive disease. As you can see, this is described in 6% of more than 40% of cases on immune checkpoint inhibition. And this is a significant problem. This is a problem that we face actually more commonly than we do with pseudoprogression. And as far as the scans are concerned, they do show a rapid increase in the size and number of the lesions. In the clinical setting, this is usually accompanied by rapid deterioration in organ function or significant symptoms. So radiologically, it becomes very difficult to distinguish sometimes between hyperprogressive disease and pseudoprogressive disease, or even true progression for that matter. But one of the clues is rapid deterioration in organ function. For example, liver mets have grown and also cause jaundice, hyperbilirubinemia. That's kind of a clue that we're dealing with hyperprogression rather than simple pseudoprogression. Pseudoprogression in the liver, for example, rarely causes hyperbilirubinemia. And those patients who have hyperprogressive disease have very, very poor prognosis. Their survival can be typically measured in months unless there is some kind of an effective alternative treatment. There are no clear consensus guidelines on what defines hyperprogression, whether the other kinds of versus the other kinds of progression. Where it is clinically important, we resort to biopsying the tissue if it is possible. Biopsy is the gold standard that can tell us whether it's true tumor progression or pseudoprogression or any other kind of problem. One of the things that is gaining rapid traction is the measurement of circulating tumor DNA. So there is evidence that following serial circulating tumor DNA quantification, because we have techniques such as next generation sequencing, now we do not necessarily need to do a tissue biopsy. We can collect a blood sample and measure circulating tumor DNA at baseline, and at specified time periods on treatment, we may be able to detect what is hyperprogression versus pseudoprogression more reliably. It's not accepted in wide clinical practice yet because it's not commonly available, and there is no long-term data. But that's one potential way we can overcome the problem of seeing whether it's hyperprogressive disease. Next slide, please. So this is a slide that just visualizes what we just discussed. Next slide, please. So this is a sequence of scans in somebody who received pembrolizumab, an immune checkpoint inhibitor for lung cancer. So you can see at baseline and after 2 cycles, 4 cycles, 6 cycles, this shows pseudo-progression. There is progression, and then with eventual scans, at least 4 weeks apart, there is regression. Next slide, please. So the newer techniques, for example, the RSI can potentially detect certain kinds of the genuine progression, especially in the brain. Next slide, please. Now, how do we come to a consensus? So all of us are aware of the RECIST criteria and their updated version, the 1.1 version. For the last 10 years, although these were originally defined for research purposes, for the last 10 years, it has become part of the oncologist armamentarium. This has become the standard way that we measure cancer lesions and follow them up and make treatment decisions over time. Next slide. As we just discussed, because of the problems we face in these unique problems we faced in this immune era, specific criteria have been developed for the immune era as well. There are several criteria, as you're well aware, the I-RECIST, the IR-RECIST. The one that we commonly use now is the IM-RECIST, the immune modified RECIST criteria. The only thing that is really new from the previous versions is the classification of any progressive disease is classified as immune unconfirmed progressive disease. And we call it an immune confirmed progressive disease only after a repeat scan, after a time interval, shows anything new or anything that's increasing in size. Next slide, please. So what are the overall clinical outcomes with these immunotherapies, especially the immune checkpoint inhibitors? Are they really worth it? So I'll direct your attention to the image in D and E. These are Kaplan-Meier plots looking at the overall survival, classified by the tumor type and classified by the kind of immune checkpoint inhibitor used. Those of you who may not be familiar with the Kaplan-Meier plot, it's a graph that has time on the x-axis and the percentage of patients are alive compared to baseline on the y-axis. So as you can see in the image D, different strokes for different cancers. In the long run, the melanoma, malignant melanomas, and renal cell carcinomas seem to be doing the best as far as immunotherapy is concerned. And on the left side of this same image, you have the head and neck cancers and the brain gliomas, which are not doing all that greatly, even with immune checkpoint inhibitors. So different cancers respond in different ways to immune checkpoint inhibitors. But more importantly, on the right side, in the image of E, I can direct your attention to the blue line, which is the anti-PD-1, PD-L1 inhibitors, which are the most commonly used now. There are certain number of people who are alive and well, even after 10 to 20 years. These are among the earliest patients treated. And remember, this data set is from the Memorial Sloan Kettering, almost like 1,600 patients from their database, from the very beginning of their clinical trials to now. Remember, 10 years ago, 20 years ago, the earliest patients were treated for very advanced cancers, which have already failed 1 or 2 lines of metastatic treatment. So it's amazing that there is about 20% of people who are alive and well many years after on treatment with the immune checkpoint inhibitors. So on the one hand, this is amazing that at least 1/5 of cancer patients we are benefiting very significantly with the immune checkpoint inhibitors. On the other hand, it's disappointing that of all people that we consider eligible for immune checkpoint inhibitors, we are not benefiting 80% in the long run. And again, I remind you that these medicines come at a price. First of all, they're quite expensive even today. And they do come with some toxicities. They do have a panoply of autoimmune problems that they can cause. The commonest one is colitis, autoimmune colitis, or autoimmune dermatitis, which we can easily handle. But some patients do have more serious side effects, especially pneumonitis, autoimmune lung disease causing pneumonitis, or the adrenocortical axis dysfunction. Sudden hypotension, myocarditis, sudden death also has been reported with immune checkpoint inhibitors. So these medicines do come with a certain price, both monetary and non-monetary. And if it's only 20% of overall patients overall that we are really, really benefiting, then how do we find which particular set of patients? How do we refine our prediction? How do we find which set of patients we are really, really benefiting from these and avoid the unnecessary toxicity to the other 80%? Next slide, please. So traditionally, what we have been using are biomarkers. So the biomarkers that we commonly use, we can measure the amount of PD-L1. As we just discussed, cancer cells do express the programmed death ligand on their cells, which jam the radar on the T cells. So because it's a cell surface receptor, we can actually do immunohistochemistry and see the staining, whether it stains for the PD-L1 receptor. And that's the most common way that we are measuring that we're trying to predict the efficacy of immune checkpoint inhibitors. So measuring PD-L1 by immunohistochemistry on a tissue biopsy of the malignancy. We come up with certain mathematical scores, the combined positive scores, which look at the proportion of PD-L1 positive cells versus all viable tumor cells, or the tumor proportion score, the proportion of tumor cells that are PD-L1 positive versus viable tumor cells, and so on and so forth. Then we also have a way of measuring tumor mutational burden. That means if we know the amount of mutations that the cancer cells are undergoing, then we can also, that is also another good way of predicting whether immune checkpoint therapy is going to work or not. The assumption being that the more mutations that the cancer cells have, the more abnormal proteins that they secrete, and therefore are more immunogenic, and therefore the higher the chances of immunotherapy to work. The way we measure tumor mutational burden is by doing immunohistochemistry or looking at gene panels, looking for mismatched repair genes, microsatellite instability, or using next generation sequencing panels to directly measure the mutational burdens and so forth. So commonly used predictive scores, these 4 biomarkers are commonly used, and they have certain inherent advantages. Most of them are immunohistochemistry based, which means that they're quite cheap, commonly available. Any trained pathologist will be able to do that. Typically, we do tissue biopsies anyway to determine cancer, and it's a simple matter to save some tissue and do these tests on that tissue. It's fairly cheap also. But in spite of these advantages, they come with a variety of disadvantages. Next, please. What is the threshold for positivity? If 1% of cells stain for PD-L1, is it positive? Is it 5%? Is it 10%? Is it 20%? So at what threshold do we consider the biomarker positive is at this point in time totally arbitrary. It's a lot of work that needs to be done before we can reliably decide on a number that is cost effective. Ultimately, the more the positivity, the better the chances of IC are working. Also, there's a wide heterogeneity in the expression of PD-L1 between cancer cells within the same tumor mass and between different tumor masses in the body. So not all cancers respond the same way. If you do a tumor biopsy and you do measure the PD-L1 or the tumor mutational burden, you are subject to sampling errors. Frequently, we face a lack of material because quite often we have to do fine needle aspiration cytology, so you don't get enough material. Or you do a biopsy, but we see a lot of necrotic material, and we do not have enough viable cancer tissue for us to be effectively able to do these tests. There's a rapid evolution of mutations in these cancer cells. Cancer cells are continually evolving, so it's a shifting target. So for a variety of reasons, it's only a limited number of patients that will really benefit with immune checkpoint inhibitor therapy in the long run. Next slide, please. This is a gap that immuno-PET scans can potentially fill. So immune scans can potentially be way better than the biomarkers that we use at this point in time. In a sense, targeted scans are one of the oldest kinds. It's been 100 years. I think it was in the 1920s that radioiodine scans were first discovered. And it has worked marvelously well, so much so that we still use it 100 years later. We still use the same technology. You can accurately define where the cancer cells are. You can accurately predict whether these cancer cells will respond to therapeutic radioiodine. And we are able to cure a majority of thyroid cancer patients with radioiodine. So there is no reason why we should not be able to repeat the same story in this day of immunotherapy as well. So the potential for the immuno-PET scans is in the prediction of clinical benefit even before immunotherapy. And will they be more effective than the biomarkers that we use now? There's a potential also for them to predict immune-related adverse effects, because immunotherapy come with their own unique adverse effects. Often, we may be able to predict potentially with immunoscans who is going to have significant adverse effects and who does not. We may also be able to predict response on immunotherapy, as we discussed in the previous slides. Next, please. Yeah, so before we talk about the immuno-PET scans, existing FDG PET, the F18 FDG PET that we commonly use now, there are some studies that show that they can be effective. You can tweak the FDG PET also to get the information that we want, because after all, F18 FDG PET can also measure the inflammatory immune response and the tumor metabolic activity. So because marrow and spleen are two of the sites that have the highest degree of immune actions in the body. Measuring the marrow SUV ratios to the liver versus measuring the marrow to the ratios in the spleen. There are some studies that suggest that they can predict the progression-free survival and the overall survival. For example, in lung cancer patients eligible for immunotherapy. Can you press next, please? And some studies that suggest that the spleen-liver ratio may predict poor response in melanoma patients on immunotherapy. There's been one study on about 60 patients with melanoma, which showed that, it's a retrospective study, that the usage of deep learning algorithms and SUV percentiles in the target organs of the thyroid, lung, and bowel can accurately predict immune adverse events even before they clinically present. Next slide, please. Can I have the previous slides? Yes. So we do have T-cell specific reagents now. So F, ARA-G, CFA, FLT, and I will not even attempt to pronounce them, are specific reagents that are specific to the T-cell. These are agents that are specifically taken up by the T-cell receptors. So F18 T-cell specific reagent PET scans may be of great use in the future in trying to predict any one of these parameters. Next slide, please. So one of the traditional problems has been finding the right tumor targeting vectors. Each comes with its own problem. You would know that better than I do. Monoclonal antibodies are the most common vector produced for conjugation. But they come with their problems, very slow clearing and the serum sickness. Single chain fragment variables have become very popular now, but unfortunately the kidney retains, and the kidney is very slow to excrete these. So there's a heavy pickup in the kidney. Mini bodies, nanobodies, affibodies are being developed. Nanobody is the smallest fragment of the variable chain that you can develop, and seems to be very stable and easy to produce. So that may be the future of the targeting vectors. Next slide, please. So where are we with immunopet scans? Immunopet scans are really in their infancy. You would know that better than I do. Most of them are preclinical mouse studies, and we are just now entering phase 1 studies in humans. And some of the earliest proof of principle human studies. One of the study looked at the anti-PD-L1 PET scan at 7 days and the anti-PD-1 PET scan done on the same day after injection, and following it serially. This is in about 13 patients, a very small number, but 13 patients of lung cancer who are eligible for immunotherapy. And it was found that these are safe, they're quantifiable, they are tolerably heterogenic, and there's a very favorable distribution. And the uptake was correlated with partial response. And it's also correlated with biopsy biomarkers. So this seems to be a good non-invasive way of predicting partial response and predicting the biomarker positivity. Next, please. There's another human study in about 25 patients with a variety of cancers with zirconium-89 labeled atezolizumab, one of the anti-PD-L1 antibodies. And this was shown to have a very strong prediction of response to atezolizumab therapy. This opens the potential that we can potentially use the same molecule in the immunopet scan that we will be using therapeutically, like radioiodine, and then predict the response to that particular molecule. So this opens up a whole new vista of possibilities. And interestingly, this study also showed that the atezolizumab zirconium scan better correlated with response than the tissue biomarkers or even the RNA biomarkers that was used. So even that is quite intriguing and is a subject of future study. And in the long run, there's a long way before these things come to clinical fruition and before they are validated and accepted. But there is a great potential that they can that we can conjugate the specific therapeutic molecule in the scan and thereby better able to predict the response, and that these may effectively be superior to the current biomarkers that we're using. Next slide, please. All of these things unfortunately come with a tremendous degree of cost, very expensive, even in resource-rich countries like the US and Europe. Now, many people are pondering about the cost, and there are many people who cannot afford these medicines because of copay issues and so forth. And ultimately, what we also need in the long run, scans are also going to cost apart from the therapies. So ultimately, what we need in the long run really is viable, cost-effective analysis, such as the NHS does in England. And who best benefits from these therapies? And how can we fine-hone the imaging to give us a non-invasive way of both predicting response and predicting before therapy, and of also predicting who is responding while on therapy, and what is the most cost-effective approach. With that, I end my talk. Thank you very much.
Thank you, Dr. Srinivas. Excellent talk, very comprehensive, and gave us a good overview. And
Thank you.
And also, give us a good overview and revision of the immune system. So I'll open the forum for questions. I can start with the question. So what is the time frame that you have routinely in your clinical practice for follow-up PET-CTs after the immunotherapy?
After initiating therapy?
Yes.
Typically 4 cycles, that's approximately 3 months.
All right.
So different immune therapies have their own schedule, but the most common schedule is 21 days. So typically 12 weeks later is what 12 to 20 weeks later is when we repeat the scan. Immunotherapies are typically slow to act, and you have a lot of inflammatory response up front. So if you do a scan too early, you may be seeing it as progressing where it's really not. You're actually seeing pseudo-progression because a lot of immediate inflammatory response. Second is the actual tumor kill is not like chemotherapy, so it's not rapid. It's actually slower. So ideally, we repeat a scan up to 3 to 4 cycles of immunotherapy.
Thank you.
Yeah.
This is Neeta. Just wanted, of course, excellent talk and overview. So I just wanted to also understand your take on the tumor microenvironment as such that, of course, has multiple factors that can be playing a role in how the immune response occurs. Can you expand on the role of NK T cells or NK cells? I think there's an increasing interest in some targets that are being developed against it. And also like hypoxia and vasculature, how much do they play a role?
Absolutely. I think it's quite well established now, as you rightly point out, that the stroma, what we call the stroma, which hitherto we thought was an innocent bystander in the tumor microenvironment, actually plays a very, very important role in tumor modulation and in the immune modulation as well. There seems to be a dynamic interplay between the connective tissue and the tumor cells and the immune system. And this is mostly mediated not only by receptors, but by cytokines as well. So cytokines released by the connective tissue stroma do interplay with the cytokines released by the cancer as well as by the immune system. And this contributes a lot to tumor modeling and progression as well. So there's a lot of cell signaling going on there and a lot of crosstalk going on there. Now, today we talked mostly about the CD8 cytotoxic T cells, because as of today, this is now the predominant pathway that we're using in immunotherapy. But obviously, it's a complex interplay. You do have a tremendous role of the natural killer cells, which are indiscriminate. They don't necessarily discriminate against cancer-specific antigens. They can have an indiscriminate kill, and therefore, when a cancer sheds its antigens and tries to become a stealth bomber, so to speak, and flies under the radar, you can recruit natural killer cells into action and still recognize the cell as foreign and achieve tumor kill. The other kind of T cells that are attracting a lot of attention are what are called the Treg cells. I'm sure you're aware of them. The regulatory T cells. Now, regulatory T cells are actually inhibitory. They're one of the brakes that are applied on the immune system. And sometimes, because of this complex interplay of cytokines between the connective tissue stroma, the tumor tissue, and the immune cells, Treg cells are upregulated, and that becomes an important way of the body defeating its own immune system and allowing the cancer to escape. So, down-regulating Treg cells, upregulating NK cells is a very active area of research.
Thank you. And I don't know if others have questions, but there are tracers that are also looking at granzyme. What's your take on a granzyme as a something that can accurately define? Because as I understand, it can also be, it's basically not specific to T cells, but it's more in the stroma again, and then can be also associated with the inflammatory process itself.
Yes, yes. So I'm sorry, I'm not too up to date with the research on granzyme, but you're right. Granzymes seem to play an important role in regulating the inflammatory process, not necessarily specific to the immune regulatory system, but they are among the cell signaling pathways that there's research on. But I'm afraid I'm not too aware of that, of the latest on that.
So it may not be, in short, it may not be as specific as just directly visualizing CD8 on the T cell itself.
Correct. These things are yet in the preclinical studies, and so it will be quite a while before they come into the human domain.
Yeah. Thank you.
Thank you.
Dr. Srinivas, I do not see any question in the chat box. So question for you, what do you expect from the imagers, or how do you come across people who are reading PET CTs in the era of immunotherapy? Do you think the reports are on board and up to date, and they do talk about hyperprogression, pseudoprogression, or there is more that needs?
Oh, yes. Overall, if you take, I think, all the experts in the community, I think there's a wide
Thank you.
variety
Your voice dropped off.
of backgrounds of wide in the amount of communication they have with their clinicians. Can you hear me now?
Yes, I can hear you now.
Hello. Yeah. So I think there's a wide variety of clinical sessions. There's a wide variety of experts in the community of different levels of communication with the clinician. So I think what, on an overall basis in the community, I think what needs to be addressed is frequent training in these rapidly evolving times, constant communication with the clinicians, because the clinicians want one thing and the radiologist wants one thing, pathologists want one thing. So a nexus where we can freely communicate between the pathologist and the clinician and the imaging specialist, I think, is really key. I think the institutions that I have worked at, in the institution that I am working at currently in Apollo, we are blessed that we actually have a very good team of specialists with whom we are in constant communication. The only way we improve communication is just pick up the phone and call. I'm sure I've bugged Jyotsna and her colleagues too many times that she doesn't even want to remember how many times I've bugged her. But and they call us at once if there is any discrepancy in the reports. So I think what is really effective is when the clinicians and the rest of the team involved, the radiologists, communicate frequently. Because as we have discussed, there is no real way of telling pseudoprogression versus hyperprogression versus true progression. There's no real imaging way to tell. So it can only be by comparing serial scans, by the basic scan, and by trying to pick up, as far as the nuclear medicine specialist is concerned, the radiology specialist is concerned, their level of expertise in picking up the subtle clues from the scans. And communicating with the clinician who can share the clinical details and the way the patient is going. I think the combination is what really helps us treat for our patients better. So ultimately, I think it's communication, right? And shared expertise.
Yeah, I cannot agree more. Thank you.
Thank you.
Dr. Srinivas, this is Amol. Fantastic talk.
Hi.
A lot of useful information for us, which I think as the nuclear medicine field is evolving, we do need more information on these topics. So this was a topic that's of interest to us. Expanding on what Saima has been asking, so there is no definite way of detecting or for us to call it as pseudoprogression or hyperprogression or just pure progression kind of a thing. And you alluded to big data and all that. So I guess there are some studies going on that are looking at the tumor growth kinetics or the rate of tumor growth and all that. I think one of the factors that you clinically use to determine hyperprogression versus pseudoprogression is a significantly higher rate of tumor growth than you would normally expect if the patient was, say, not getting treatment with the immune checkpoint inhibitors. So are there any thought processes to use say AI-based algorithms to look at these things from prior pets? One of our pet peeves, and no pun intended, is lots of times we don't have a prior pet before you start the immune checkpoint.
Correct.
And I think having that as a baseline and getting a sense of how fast the tumor is growing and what the tumor burden is, and not just a single site, but the overall tumor burden. And then, doing it after a few months, the first time you're assessing treatment, and then have a conversation with our referring medical oncologist, like, hey, how is the patient doing clinically? Because lots of times in pseudoprogression, the patient is stable, at least not progressing from a symptomatic perspective, or at the most minimal progression. But I expect in hyperprogression, the patient may be clinically deteriorating as well. So maybe try to incorporate that And the way we practice in the US, lots of times we don't get the right clinical information without the benefits of AMR, but really lots of times we don't have that information. So food for thought on that, to develop methods to look at it, because that's going to basically help you and us to provide us good reports to you. And the second thing I wanted to bring up was the CAR T therapy. I mean, we talked a lot about immune therapy, but even in CAR T, as you rightly pointed out, the durability of response hasn't been assessed that well. We have some good short-term response, but eventually, I think a lot of patients are actually relapsing, and they do pretty bad once it relapses. So if there are ways to predict who's going to relapse sooner than later, I think that would be another avenue of exploration. There's some data about using PET scans for that as well, but I'm not sure how good or if you have any thoughts on that as well. Since it's not done much in India, I'm just curious what your thoughts are though still.
Yeah. So I couldn't agree more with what you said. You're right. Communication, I think, is a very important thing. And this AI seems to be very, very interesting. I think the last ASCO, you must have seen the articles on AI. There was one particularly very intriguing one where they combined AI with ultrasound. Just simple everyday ultrasound was combined with the AI process, and it was accurately able to predict which thyroid nodules are actually malignant versus are benign in the neck, the nodes and the thyroid nodules. So, you can potentially have non-invasive ways when you combine this big data and AI eventually in refining radiology methods. As far as the PET is concerned, in India, we don't see that problem too much because virtually everybody gets a PET scan here at baseline. For one, here PET scans are done with full diagnostic quality CTs. It's not the attenuation CTs that they do in the US. It's actually done full. And the cost disparity is not much. The cost between a contrast enhanced CT versus a PET CT is actually marginal. So most oncologists just go ahead and get a baseline PET CT scan anyway. We may not repeat it eventually. We may choose to do just a plain CT later on. But at baseline, we do get PET CT. So we don't see that problem too much in India. But I can imagine that in the US, that would be an issue that we don't have a baseline PET to compare it with. So I think I'd agree. As far as the CAR T cell therapy is concerned, you're right. There's a lot of hype with it, and then we're all excited about it because the response rates are so dramatic in people who are so heavily pre-treated, who you don't expect will respond to anything. And we hope and pray that the day will come when CAR T cell therapy can potentially supplant bone marrow transplantation. That day may yet come, and we don't need to do bone marrow transplantation. We just do CAR T cell infusions. It has that kind of a potential, but unfortunately, we don't know what they will do in the long run. They come with a fairly heavy toxicity, so we don't know if in the long run the survival will beat the people we lose from the side effects. And you're right, when they come back, they do come back with a vehemence. And yeah, we do send our patients out for CAR T cell therapy and they come back, and a lot of them do recur. They have a period of time when they're free, but they do recur. And when they recur with a vehemence, and we really don't know what to do with them at that point in time.
Interesting. One last question before I know we are running out of time, but immunotherapy has been combined with chemotherapy. So we have chemo-immune regimens.
Correct.
Any thoughts on combining immunotherapy with targeted radionuclide therapy?
Oh, yes. I mean, so there are quite good trials going on. So chemotherapy and immunotherapy combinations in several settings and several malignancies has already become quite well established. And we know that on a molecular level, the certain kinds of chemotherapies actually seem to upregulate the PD-1. PD-L1 expression on tumor cells. So one of the ways that certain kinds of tumors respond to chemotherapy is by upregulating their PD-L1, which makes it easier for immune checkpoint therapy to work. So we found that immunotherapy is effective in cancer patients when used along with chemotherapy, even when the baseline PD-L1 expression is low. Lung cancer is a classic example. So on the same theme, the combinations of immunotherapy with targeted therapy are also being, they're an area of exciting research. There's a lot of good data out there. One of the areas where it has come to fruition really is lung cancer. So osimertinib is an EGFR inhibitor specific for T790M, for example. So that's a targeted therapy that you take as a tablet in advanced lung cancer. And the responses are very good, and the survival, overall survival, beats most other agents that we use in this situation. But there will come a time when these people progress even on osimertinib, for example. And we see a lot of differential responses with osimertinib. Sometimes it so happens that you have a moderate progression. In other words, you do not have a stormy progression. There is still pretty good response in predominant sites, that there is a moderate progression in certain sites. And these cells that are progressing, the tumor cells, do seem to overexpress PD-L1. So you can combine them potentially with immunotherapy, and you can still get a repeat sustained response for a long amount of time. So you don't have to stop dosimertinib. You can continue dosimertinib and put them on immunotherapy, and they seem to respond quite well, even for many months after that. So the combinations of the other, of course, famous combination is in recurrent melanoma. So that's another area where we are using what is called a MEK inhibitor along with an immunotherapy agent, and that's shown quite good survivals compared to alternative forms of therapy or immunotherapy alone.
Then it kind of becomes a tricky question for us when we're assessing response with the combination model. Is it progression or so we do need to talk much more and come to a consensus on how to interpret these scans.
Absolutely. I think there's a lot of work going on in creating a consensus. You know that better than I would. It took a lot of effort to come up with the RECIST, if you remember.
Yes.
So there is a lot of interest in creating consensus guidelines for this new era of targeted therapies, immunotherapies. But one of the problems is the field of immunotherapy and target therapy itself are very rapidly evolving. So it's like you're chasing a running target. By the time you think you got it all figured out, then something changes completely. So I think that's one of the problems that everybody's facing, that a rapidly evolving field. How do you keep up with the variety of parameters that we need to know?
Thank you. I appreciate all your thoughts.
Truly appreciate Dr. Srinivas for your excellent talk. And with that, I thank you again, and thank you to the audience as well for taking time. And I apologize for the initial, technical issues that we were having. I'll see you next month, same time.
Thank you very much. Bye-bye. It was very nice.
Bye.
Thank you so much. Bye.